Good night, good evening. Thank you very much for coming at this late time, almost 8 o'clock on day 2 of Soho, so people must be very tired. I'm actually extremely honored to be here with Dr. Amy DeZern, that is not only a close friend, but I consider her the top leukemia MDS doctor in the country and a great colleague, so thank you very much, Amy. And with that, we're going to start with this meeting. So as you see, the title there is called Resetting Standards in MDS. I think if you were yesterday at the Soho meeting, you saw there's a lot of stuff happening in this disease, and we're happy to basically continue sharing some of this information. So again, my name is Guillermo Garcia-Manero from MD Anderson, and I'm here with Dr. Amy DeZern from Johns Hopkins. So thank you again to our supporters, the Medical Learning Institute and Peerview, for providing this session, and BMS and Geron actually for providing the educational grants that make this possible. Please do your survey. Please look for additional polling during the presentation. I believe you should have an app and you should be able to ask us questions. I think you have instructions, and you can get this to this QR code for learners. And also you can go and visit this website, peerview.com, MDS Houston 24. That means that there's going to be a 25, I guess. So that's good. And please also complete and submit your post-test and evaluation for credit. You can actually download the slides and the practice aids, so that thing will be educational. Sometimes myself, I need a little bit of time. And with that, thank you very much again for joining us. We're going to start with the first question, if you can do that on your device. So reflect on your practice and choose the options that you think represent a challenge or question in the management of MDS. You can select all that apply. So do we get the polling working? Thank you. Do I advance? So I'm gonna, sorry, I forgot to read the question. So interpreting modern MDS classifications, integrating new prognostic tools into practice, such as the IPSSM, addressing transfusion dependence, initial and sequential management of low-risk MDS, and treating high-risk MDS, in particular, let's say, P53 mutated disease. Now, please go ahead. Sorry about this. Thank you. Okay, so I very quickly saw that there's nice distribution, and I think this is a complex group of diseases, and we all kind of struggle with some of these issues that were on the slide. So with that, let's start with some introduction before we go into the actual meeting itself. So Amy and Dr. DeZern and I can attest that until maybe 2020, we were really kind of thinking about abandoning this field, maybe, I'm not sure. Because since I think 2005, 2006, we were not able to get a drug approved. And it's good to get new classifications and get a lot of papers, but actually we need to really help our patients. And then we saw the first approval of luspatercept, this TGF-beta modulator, for patients in second line with neoplastic anemia. Then we saw the approval of the decitabine cedazuridine, an oral hypomethylating agent. This is actually a very I think special drug that is really going to be a very important part of our armamentarium. We kept doing research, came out with the IPSSM, and then we were able to get luspatercept approved in frontline for any patient with low-risk MDS transfusion dependent. And then very recently we saw the last, not the last, almost the second to last approval with imetelstat, a telomerase inhibitor for patients with second line, any type of low-risk MDS. And the last one actually is the approval of the IDH1 inhibitor, ivosidenib, for the group of patients with IDH1 mutated disease. I want to say something very quickly about this because I don't know if there is anybody from the sponsor that has this drug, but I actually think that that's quite good, because this is not the most frequent mutation, and to have a sponsor take the lead and make sure that we can get this extremely effective therapy for a very small group of patients is actually something that I think is quite remarkable. So I'm thankful for that. There's some diagnostic criteria and differential diagnosis for MDS. Actually, to be honest, this is becoming a little bit of a nightmare even for us. You know, we go through entities such as clonal cytopenia of unknown significance. We're going through kind of new diagnostic classifications like the World Health Organization, this ICC. So we're a little bit in kind of flux in terms of how we really call these diseases. But the bottom line is these patients in their bone marrow have particular morphology that we call dysplasia. They have some degree of bone marrow failure that is manifested by the cytopenias. And basically, we put all this together with the molecular panels, with the cytogenetics, and we come with a diagnosis and hopefully a way to prognosticate these patients. Of course, there are other entities that can cause this type of bone marrow failure, and many of them are actually non-clonal. Simple things that actually we very rarely see nowadays, I think in North America at least, like B12 folate deficiency. I have to say that occasionally you see a patient with HIV disease that you think has MDS and it turns to have this other highly treatable actually today condition, and some of the other things that you see there. As we actually improve in our molecular knowledge of this disease, we are starting to understand that there are some not very frequent, but actually common familial traits or hereditary leukemia traits that actually can manifest as MDS, and indeed Dr. DeZern is an authority on that. We're seeing more and more cases with therapy-related disease because our friends in solid tumor oncology and lymphoma doctors and myeloma doctors are actually very successful now in curing those patients. So unfortunately, sometimes this results in this type of secondary leukemias. Sorry. Okay, so that's what I was referring about earlier. At MD Anderson, we go by WHO classification. That said, occasionally our pathologists will use the ICC to help complement. The reality is that there are not big differences between these two models, and none of them are perfect. So I'm going to be, Spanish people sometimes are negative and from Spain. So for instance, I didn't like from the WHO that they changed the name to myelodysplastic neoplasm because I think MDS is a really syndromic entity that is associated with comorbidities and a lot of other things. So I think narrowing it is maybe something that I didn't enjoy. And then changing EB for IB, this kind of things makes my life complicated. And from the ICC, there are some positive things. I don't like personally that we start calling this disease AML because it's easier to put patients on clinical trials, but maybe Dr. DeZern disagrees with me. The reason is that the biology, the type of patient is totally different. And I think actually these AML doctors may, that we are also, they may get too much if they think that by incorporating these kind of patients into AML trials, they're going to help. They may actually not make progress in MDS, and they may actually affect it in a negative way, their trials. But that's a philosophy maybe for later. I think where we have really benefited is from the incorporation of molecular data to our patients. And you may or may not know this, but I serve you as this year president of SOHO. So as president of the society, I have to come with a theme around 12 months ago. And the theme was kind of, I don't remember exactly what the title is, but basically the international aspect of SOHO. You know, how this is a really international community that comes here every year. And therefore, actually, through the meetings, probably you noticed that we had the speakers from Brazil in the AML session telling us what they do in Brazil. This morning, we had Dr. Zapata telling us what they do in Mexico. We had the AYA program in Mexico City. And there's huge gaps and differences between maybe Houston or Baltimore, United States, and some of these other countries. And these countries actually are not poor. I don't think Mexico is a poorer country than Spain or Brazil or maybe Argentina. I think it's about how we organize health systems, etc. So this is very critical because I'm seeing that there's now kind of a dichotomy where we're moving very, very fast into very sophisticated knowledge that may not be translatable right away to some of these other countries. So bottom line is, this is a tool that we think is democratic and easy to access that may not be something that every leukemia physician can use all over the world. But we use this all the time. And this is actually now a very precise tool for us to really predict what's going to happen to this particular individual with MDS. And this is really a fantastic tool that is the result of almost 10, 15 years of sequencing, trying to find genes, and then really putting a large cohort of patients all over the world with MDS, resulting in this free tool known as the IPSSM. Now, the question is, we have these tools, and can we do better with therapies? And again, this slide is very important to me because when Dr. DeZern and myself write a review paper on this disease, we start saying something like, in low-risk disease, we want to improve transfusions. In high-risk disease, we need to cure them. Well, actually, low-risk disease is not such a benign disease. These people actually may die from this condition a few months, a few years after they're diagnosed. And therefore, just thinking about this type of approaches as supportive care may not be actually the right thing. And indeed, now I think the field is moving towards what I call the left, almost like early intervention, thinking about treating clonal hematopoiesis, clonal cytopenia. And what we're starting to see is that these more potent drugs that help, for instance, improving transfusion needs, etc., may be associated with a change in the natural history of the disease, potentially survival. So we are actually trying to achieve that. Can we start curing these patients from kind of like the earlier stage of the disease, not just when they are really transforming into probably an incurable condition, transformation to acute leukemia. Again, in high-risk disease, maybe we are not that optimistic, as you're going to hear a lot of progress in low-risk disease. Here, if you were at the session yesterday, we're a little bit kind of stuck. We're waiting for a major trial called the Verona trial that hopefully we'll read in the next, at some point they say, we don't really know, but early next year. That's really an important study for us. That's a randomized study with azacitidine versus venetoclax. But during the session, I was asking the colleagues that were speaking is, what is plan B if that is negative? Dr. DeZern is leader on a very specific approach, targeting retinoic acids. But the reality is that we hope that it's positive, and maybe we can have triplets, if not with the tamibarotene, but we need to start thinking about some plan, and perhaps actually a scaffold or a combination with HMA moving forward may be something that we need to start thinking about removing. So with that introduction, these are the goals for today. I hope that we can improve your knowledge in terms of the clinical and molecular features of this disease, so you can inform the accurate diagnosis, prognostication, treatment. I hope that will also help you understanding and supporting the use of the new therapies that I discussed earlier, these approvals that we had over the last few years, and hopefully also enhance your skills in terms of team-based treatment. I have to emphasize this. At my institution at MD Anderson, I don't know when they do that at your place, but it's Thursday morning, 8 to 9. That's the most important meeting. A bunch of people get together with the pathologists, with the physicians, and we discuss every single new case that is referred to us. It takes 5 minutes per case or something like that, 2 minutes, fundamental. So this is a team effort that I don't make a decision by myself in isolation. We really need a lot of people to help us with these patients. And with that, I think we introduce ourselves, so we can start with the first case. So we're going to talk about this man, a 74-year-old Michael with low-risk MDS. He comes to see you with fatigue, anemia. You do your CBC, hemoglobin is 7.4, platelet count is 250, ANC is 5,000. And you do a particular stain. And actually, I may take 2 extra seconds here because I didn't think about this. So when we were first doing some of the trials that we're going to discuss in a few minutes, I thought actually that ring sideroblastic anemia was a very rare entity because it did not exist at MD Anderson. Why? Because our hematopathologists, these people that Thursday at 8 helped me so much, they thought it was not important. So we didn't do this stain that you see there, particular iron stain. So when we were seeing the first trials, we were like, okay, there's like nobody with this disease. And then our pathologists actually very quickly realized this is important. And then the SF3B1 gene was found to be frequently mutated in this condition, and the field really changed. But I learned actually that this kind of staining is not something that everybody does. So some people are like MD Anderson maybe 10 years ago or something like that. So if you don't have molecular data and you don't do the stain, you may not be able to treat these patients because you don't know that they exist, basically. And this is a very simple test. Okay, so you don't need sophisticated NGS sequencing to get this done. So that is trivial. Actually, it's becoming really, really important. So you do the test. Basically, the test will be a bone marrow aspiration with a biopsy. You see the morphology. You see that actually, I think I can make it work. Let's see here. You see these blue things. These are the rings. It's kind of like a morbid analogy because I guess this is the finger of a dead person with a ring or something like this, and the pink is the bone. But basically, this is pathognomonic of this condition. And there you're also going to count the blast. So this person has low percentage of blast, 3%. You do your next generation sequencing test, and almost universally, maybe 90% of these cases will have a mutation on this gene that is a very fundamental gene controlling splicing. This is a very important molecular mechanism that controls a lot of functions in our cells. And this person now, because that hemoglobin of 7.4 is dependent on red cell transfusions. So now you go to this machine, you calculate this IPSSM, and basically what you will see is that it's going to ask you characteristics of the patient, what is the CBC, then it's going to ask you what are the cytogenetics that we didn't discuss here. I think most likely this patient is going to be diploid. Then it's going to ask you what is the P53 status. This is actually the most important gene, probably after SF3B1 in this disease. Likely this patient doesn't have that mutation. And then it's going to ask you just no, the other genes that are frequently mutated in this disease. And then it's going to divide this into 6 potential situations, from the very low risk to the very high risk. This patient with this feature likely is in what we call lower risk condition because of the low percentage of blast, normal karyotype, and actually mutation that is associated with good prognosis, that is this SF3B1 mutation. So we continue with this evaluation. He comes with these counts. Another question is there an intervention necessary for this patient? Because I just dropped something where I said this is a good prognosis mutation. Actually, the survival of this patient, let's say if he has what we call an SF3B1 K700T mutation, could actually be a decade. So this is not, a bad thing to have. But the problem is, compared to other MDSs or leukemias, is that this patient is going to be dependent of these transfusions, right? So now the question is, what will you do for this individual? Traditionally, we will maybe watch this patient, transfuse, maybe consider some type of erythroid growth factors, but you see that his transfusion needs, they continue to accelerate. So now, over a 2-month period, he received 6 units. This is actually interesting because now we're starting to call this type of patients based on their transfusion burden into low transfusion burden, let's say less than 4, high transfusion burden more than 4. So now the question is, what do you do? You're seeing this patient today in the United States where this drug is approved in first line based on a study known as the COMMANDS trial. This was published last year in Lancet, was presented at ASCO, EHA plenary, ASH, and then the final paper was just published a few months ago in Lancet Hematology, a huge international effort by a lot of us in this room. So now the question is, in this patient, should we use this TGF-beta modulator, luspatercept, or should I use a conventional standard of care that we have for close to 20 years, an erythroid-stimulating agent, and then see what happens, and then maybe use the luspatercept in second line. Remember, this patient has RS-positive disease, so this patient has ring sideroblastic anemia. But the question that is happening is, what will happen if this particular patient actually was RS-negative, didn't have that iron stain, didn't have the SF3B1 mutation, and this was basically what we refer to as an unmutated low-risk myelodysplastic patient, okay? So this is the standard. These are ESAs. Probably they are generic. There are many ways to give them, different ways to really approach them. And this is actually very interesting, and I don't think this has been fully explained in, at least what happens in North America. These transfusions are actually not free. They are expensive. They require time in a chair for our patients. They're associated with actually acute and chronic complications. And we learned actually through the COVID times a lot about what happens. MD Anderson is the biggest blood bank in the world for a single institution. You have to see the investment in terms of our transfusion pharmacovigilance unit. It's actually quite a complicated type of a story. And I don't see actually that implemented in terms of the pharmaconomics of these drugs. So by a number of studies, actually more than a decade ago, people started to investigate these drugs that somehow modulated in a very interesting fashion this pathway known as the TGF-beta pathway. And it turns out that activation of this pathway is associated with inhibition of erythropoiesis. So let's see if I can explain this right. If you activate this pathway, somehow you inhibit the capacity of your bone marrow to make red cells. So therefore, if you inhibit the pathway, you basically promote erythropoiesis again. Now, the way this drug works is actually by binding to the ligands. So they trap the ligands that activate this TGF-beta pathway. So kind of in an indirect way, they are stimulating erythropoiesis. It doesn't act at the same level as a traditional ESA that is kind of more proximal to the erythroid stem cell. It's actually more what they refer to as an erythroid maturating agent. And these drugs are actually quite interesting because they probably are not specific for RS-positive disease. They have significant activity in conditions such as thalassemia, and probably they could have other roles in helping us, our patients, with these kind of conditions. So we perform, actually there were 2 drugs that were developed kind of in parallel. Number of course phase 1, phase 2 trials. And we started to learn about the toxicity profile of this compound. We started to learn about how to use them. And the first study was a study known as MEDALIST. That is what served to the first approval of luspatercept in 2020. That's a study for second-line patients, meaning they have already been treated with an ESA or they potentially will not benefit from such a drug for RS-positive specific disease. So that was the first intervention, plenary attached, New England Journal paper, but we wanted more. So we said, okay, how do we move this forward? So we designed the study known as the COMMANDS trial. And I think this is a really important study because if you follow this, you will see that we're actually learning with each study in terms of how we design the primary endpoints. What type of data do you need before considering a patient for a study like that. So I actually think that the primary endpoint on the COMMANDS study is really quite robust. So here what we were looking for was in any patient with lower risk disease that was transfusion dependent, randomized luspatercept versus epoetin alpha. This is an ESA that is used kind of worldwide. A responder will be considered, as you see there, as someone that achieved transfusion independency for a period of at least 12 weeks, but also with a concomitant increase in hemoglobin of at least 1.5 grams. This is actually very different than the MEDALIST, where I believe, if I remember correctly, that we had like 8-week transfusion-dependent period or something like this. So we become actually more kind of stringent in terms of how we call these responses. And as you see there, the response rate with the luspatercept was 63% versus 42% with the control. And this was actually extremely significant and basically led to the approval in the United States and now basically going through every country that has access to these drugs as a first-line agent for patients with low-risk MDS. Now, I'm okay with this response stuff, it's very nice, but actually what I'm more impressed or what I look for is actually the duration of these responses. This is what I refer to as the quality of this response. So what you see here is that those patients on the luspatercept not only had a higher rate of response, the duration of response was significantly longer. So in fact, if you see there, the median response was around 126 weeks versus 89 weeks. So this is actually quite significant improvement in the duration of the response compared to the luspatercept. So not only you're going to have more responses, they're going to be actually of significantly better quality. But I think what is very interesting, and this has created at the beginning a little bit of controversy, is when we go into plan sub-analysis of the study. So this is not something that we did post-hoc trying to figure out, no. So what you see here, earlier I mentioned the transfusion burden, right? So if you start through here, let's see if I can manage to, yeah, here. So you see that for patients with a lower transfusion burden, response rate is 73%, more 50%. This is very important in practice, because now the question is, with that individual that already had like 6 units, when do you move into this therapy? The message is the earlier, the better, if you really are going to use this compound and really want to use it very effectively. Very interestingly, traditionally, we look at the EPO levels. So here you see less than 200, 250. Look at those patients actually with more than 200. The response rate with epoetin alpha is actually less than 10%. It's a really low rate of response. So this is actually all in favor of the luspatercept. For those patients with SF3B1 mutation, very clear. This is a drug that is very effective in that particular genotype. And here is where we have had a little bit of a question, and we could be discussing this a little bit later, that is actually this issue of the RS positive versus the RS negative response. There is actually no molecular basis that I'm aware of why this drug will work better in one disease versus the other, meaning rhinoblastic anemia versus none. Of course, morphologically, when you associate that, it's very clear, 67% versus 39%. In the first interim analysis of the COMMANDS trial, the response was a little bit greater for those patients that were RS negative. That created, in my opinion, a little bit of confusion. I don't think that colleagues that actually are top centers realized that maybe these responses were kind of neutral, but actually the duration of response is significantly longer also for luspatercept-treated patients in the RS-negative context. But then in the final analysis of this paper that was just published in Lancet Hematology, it's actually 53 versus 50%. Is that superior? I don't know. I will call them the same, if you will, but the quality of those responses is significantly longer also for the RS-negative group of patients. So what would you do with that patient? Today, this patient, I think in most centers with RS-positive disease, treatment naive will be a candidate for luspatercept, and this is actually considered now the standard of care for this particular subtype of patients. Now, how do you use these drugs? This is actually quite interesting. Remember, this is a monoclonal antibody, has a long half-life, so we inject this every 3 weeks. But the FDA was, and I said that with respect, actually I like the FDA very much, I think they're really smart people, but they came with some guidelines in terms of how to dose this. Because really you don't want to give this drug to a very high dose and the next day have 20 grams of hemoglobin. That's it, I've never seen that happen. The fear is that in the early days of erythropoietin-stimulating agent development, there were some patients that had some type of strokes, there were cerebrovascular events, these kind of things. So we have kind of algorithm in terms of how to use this drug. So you start at a dose of 1 milligram per kilo. Let's say you wait a couple of doses, so remember every 3 weeks. Then you can move to 1.33, 1.75. Most likely, if you use this drug correctly, that is, when these patients start needing transfusion, remember the label is for a patient that is a candidate for transfusion. So you actually don't need to be technically bi-label dependent on the transfusion. It is possible that these patients could have a long response at 1 milligram, and then a few months on therapy, they may need a transfusion. This is a very important point of discussion because you will not stop therapy there. Likely you will increase the dose to 1.33, you will do the same, and then eventually you will go to the maximal dose of 1.75. There are some studies looking at acceleration of this or starting at a higher dose, but you under the current recommendations. So that's actually important. Why? Because when we got this drug, MD Anderson was the first in the country to have it. Some of my patients will call me, can you tell the doctor please at home to really increase the... So, I mean, this drug is used not only by hematologists, but by community oncologists that are super busy. And, at the beginning, when you have a new drug, this may not be common knowledge. There's actually now an issue in terms of can we do better? So people are starting to say, can we combine this with an ESA? Can we combine this with some other drug? There is some rationale to do this kind of thing. I think my advice to you is select the patient right. Start with patients that have low transfusion burden in the right condition. Maybe today you will not need to do this kind of combinations. But this actually occasionally happens. Okay. What about toxicities? These are not cytotoxic agents, so there's not a lot of toxicity. And it's quite interesting because when we had to do this analysis, basically patients on the luspatercept were almost as long on therapy as those on ESA. So if you put that, it looks like it's more toxic than ESA. So we had actually to adapt this for that type of analysis where you adapt or adjust for time on treatment. And basically when you do that, is identical to the ESA. There's no rate of transformation, there are no deaths associated with this compound. So I think overall it's a safe compound. So we already discussed the dose and the schedule. I actually have never seen this, and I think we've treated probably over 150 patients at MD Anderson with this compound by now. Issue of hypertension management, these kind of things. I don't know that this is a signal that I see routinely in my practice, but this is the type of thing that the FDA will be concerned, increases in hemoglobin, issues with hypertension. This is, the first time I saw this actually, this is from the meta list, not from the commands. I didn't understand it. I love this kind of diagram. And I call this like a transfusion swimmer plot or something like this. So basically, let's see if I can explain this. This is kind of important. So to be part of this trial, you have to be transfusion dependent. I cannot really do the, okay, here. So each dot is a transfusion. So to be part of the study, you have to be transfused. And then blue is basically you are okay. And occasionally you need a transfusion here and there. So for instance, these first 3 patients started drug. They had a really super fast response. They're doing great. But then if you look here, let's hypothetically do this case here. So this person is getting transfusion, start the 1 milligram. I don't know if you can see that. And then here he gets or she gets a transfusion. What do? Most likely there you will increase to 1.33, And then I think there is a subsequent point where the same thing happens, and probably you will increase to the 1.75. This is just hypothetical. I don't know if this is what happened to this patient, but you will do something like this. So now we're starting to talk about when do you call an ESA failure? When do we call a luspatercept failure? And for years, actually, we treated these patients with ESAs for a long period of time without really interrupting these therapies. So let's then answer this question on your device. So you have the 74-year-old man with low-risk myelodysplastic syndrome, ring sideroblastic positive, without a chromosome 5 alteration, with anemia, who is transfusion dependent. And now the transfusion burden has increased over this 2-month of period. How would you now, today, treat this patient? So I'm not sure. Continue with the transfusions. We'll see what happens. Start an ESA like epoetin alpha, start luspatercept, or start ESA, and then I'll figure out what happens, and I may add later on luspatercept. So maybe we can vote now, please. Thank you. Okay, I'm not sure, so I need to improve. For sure, you will continue with the transfusions. Actually, this is important. This is actually kind of tricky because you will not just stop transfusions, right? So you will continue the transfusions until your patient will stabilize and respond to therapy. Some people will start ESA therapy. Actually, that will be the standard of care. But the majority of you, 68%, will now less. Okay, will start the luspatercept. And this argument at the bottom of starting maybe a cheaper drug at the beginning and trying to see what type of sequence is something that we hear. But the most robust approach here will be luspatercept. And indeed, if you allow me to tell you, you will not wait 2 months and 6 units of transfusions before you start therapy. Actually, you will probably start that therapy immediately after you have diagnosed this patient and this individual has received 1 unit. Okay, so now we're going to talk about the dosing strategy. So let's see how did I do. Okay, so the first answer is I'm not sure how to dose it. The second, I start at 1 milligram per kilo every 3 weeks. No titration necessary. I go directly to 1.75. Dose titration based on response, or 1 milligram per kilo every 3 weeks. Dose titration based on response. So please vote and make me look good. Okay. So you will start at 1 milligram kilo, so that's correct, but there is dose titration needed. Remember, you may need to increase from 1 to 1.33, 1.75. You will not start at 1.75. That's actually not allowed. There's a study looking at this, but you will not be doing that. So the right answer is the one at the bottom that 55% of you achieve. So you start at 1, and then you increase the way I mentioned to 1.33 and 1.75. Okay. Now what's happening is, remember we talked about medalist, that was second line, then commands, first line transfusion dependent, but at the beginning I mentioned that we're starting to think about starting therapy early. So it's actually a study known as Element MDS that is actually active, ongoing. We just put the first patient actually a couple of days ago at MD Anderson for patients that are transfusion independent. This is going to be a really interesting study. So it's basically starting therapy as soon as possible in these individuals before they need this transfusion. So you're going to see this theme, like really an early intervention type of concept. The study is kind of similar in its design to the commands trial, is that we start significantly earlier than in commands. And then there is this question about combinations. To be honest, this question, I don't know how, well, this is an international meeting, so, but it's kind of geographically different. In some countries, the drug is approved under medalist, meaning second line. In some other countries, like United States, it's approved as commands. I'm sure that there is some second-line use in the United States, but probably we're going to be migrating towards first-line use. So this question may or may not be relevant today, but it opens a lot of opportunities. So this is a study by our colleague and friend, Dr. Rami Komrokki from Moffitt, where they did a retrospective historical analysis in their practice of people that were mainly on erythropoietin, and for some reason, don't understand why, the drug was continued, and then they added the luspatercept. I think that's most frequent sequence. And what you see there actually is that there are some patients that respond to these kind of therapies. This opens, in my opinion, two questions. One is, if we use this drug today as commands, meaning luspatercept first, could there be actually a value of adding an ESA to maybe prolong the duration of response with this compound? But most importantly, the question is it possible that a doublet upfront, ESA plus luspatercept, because they act in different levels of erythropoiesis, as I said earlier, instead of giving us a 70% response rate, could give us a 99% response rate. So this actually started to be investigated. There is a study looking at this combination, but this is not what we do, right? So you're going to start with this drug as a single agent upfront, following the guidelines that we discussed. So we are not recommending here this kind of sequence or this kind of combinations. Okay, so what if actually Michael had received prior ESA but experienced loss of response? So this is now the medalist indication. So we're now going to actually the original indication. Again, he's anemic, he has the same bone marrow with the ring sideroblast, he has these transfusion requirements, and this is now a question that we don't really have a clear answer, that is, how do you call an ESA failure? This is becoming really critical because these new drugs probably are not that cheap, and if you use them very late in patients that are super transfusion dependent, maybe the benefit of them is going to really decrease. So you'll be much better off using them early on where you're really going to get the maximum benefit. We don't have real clear guidelines in terms of what is an ESA failure. In other words, when are you going to switch from erythropoietin-like drug to this compound if you use luspatercept in second line? My advice is transfusion burden is probably the most important factor, if not one of the most. And I think you should really transition faster in those patients with an ESA. And then you saw the data. You know, you have an EPO level more than 200, response rate is like 10, actually less than 10%. So we should probably start thinking about moving as fast as we can. I think in that context, this medalist data will suggest that you switch to luspatercept. But now we actually have a second drug. When do you start, actually? No. That is a really interesting compound that is going to give us a second opportunity also for second line. Right, Dr. DeZern? Yeah.
So we are in a privileged place, and Guillermo alluded to a lot of fun things that we've been able to do over the past 4 years. But just to reiterate some of the messages, we really are trying to change the natural history of the disease for these patients. And in addition to extending survival for the individual patients, from a healthcare resource perspective, gaining transfusion independence is also important because the National Red Cross is at an all-time low for its red cell supply. So all of these interventions are really fun. But exactly as we've been talking about, we need to use our newer agents earlier and sooner. Imetelstat is something that will go into some of the data, and we also continue to reassess those molecular mutations. He spoke about the IPSS-M at the time of diagnosis for our patient, Michael. But what if he had had an IDH1 mutation? We really want to make sure we have all the data available to us so that we can really make sure the patients get the treatment that they need for their disease. Just to tidy up the luspatercept story in the erythropoiesis-stimulating agent refractory setting, it is important if you are still meeting patients in your practice who maybe they've been a long-term ESA responder, but they ultimately really burned out that part of their erythropoiesis, or they became so iron dependent that it wasn't possible. It really is time to switch to luspatercept and reduce that transfusion burden. It's sometimes, I think, challenging in practice when these patients continue to perhaps just have their regular visits, and it's not always readily available to make a transition for whatever reason in that individual practice. And so continuing that treatment after ESA, once luspatercept has been initiated, is really important to try and maintain transfusion independence, ideally, or transfusion reduction, which is really the swimmer's plot that Guillermo showed that matters for these patients. So talking about new drugs, imetelstat is our latest arsenal agent, and it has a completely different mechanism of action than anything we've ever seen. And what you're sort of seeing in the low-risk space is biologically, we had ESAs for a long time, transfusions. Those probably don't ultimately modify the natural history of the disease. There are some people that think through the SMAD signaling pathway that was described earlier, that luspatercept might have that potential. But then we come to imetelstat, which is really a very different drug. And it's a unique mechanism of action through telomerase inhibition, and it targets the malignant myeloid clonal stem cells and causes apoptosis. And then hopefully, and what the trials have shown clinically, is this allows recovery of more normal hematopoiesis, even in the diseased marrow of an MDS patient. So this was just approved over the summer, which has been exciting. And it's a very specific approval, and you are going to see sort of a little bit of gray area as we've moved through our various classifications and prognostic systems. It's currently approved by the IPSS with low and intermediate 1 MDS, with a different endpoint than the very clinically patient-friendly endpoint that was emphasized for the commands, whereas that was a longer period and a requisite hemoglobin augmentation. This was for transfusion-dependent patients who had lost their response to an ESA over an 8-week period, is how the endpoint was determined. And we put this into the NCCN guidelines very efficiently, making sure that everyone had the support they need to give this to their patients. And this data was presented from the iMERGE trial. It had originally been a phase 2 enrolled into a phase 3. And as you can see, the active therapy patients treated in the sort of navy blue for the imetelstat had a remarkably higher transfusion-independent rate than those who received placebo. This was true at 8 weeks, it was true at 16 weeks, it was true at 24 weeks, and it's still true at a year. So remember, he alluded to the fact these patients can live for a decade. We want to keep extending the time that they're not getting transfusions, and this was quite a positive trial in this setting. Duration does matter, and you can see that it was almost a year for the imetelstat arm for those who did respond. There's quite a nice separation in curve there, and I think it's really important when we counsel our patients that we're trying to change the natural history. We'll get into a few of the side effects, but it can be really meaningful for the transfusion independence. And this recapitulates how long patients can go without needing a transfusion. So in the imetelstat treated patients in the top, which are these, you can see that you can have very long periods of transfusion independence for greater than 8 weeks in many. And there are also patients who it's punctuated, just as you saw in luspatercept, by transfusions, but that then they can regain more of that period of blue where they have an 8-week window where they don't get transfusions. So this was certainly better than placebo and why it came to approval. Sorry. We won't advance.
I think the slide got stuck.
Thank you. So as we move towards modifying the natural history of MDS, we want to make sure that we're not causing more and more side effects to our patients who do have comorbid illness and perhaps are a bit older. And this drug is more myelosuppressive than the agents we've spoken about up until this point. And so neutropenia was common, as with thrombocytopenia. But what was known is if you held the drug for 2 weeks or 4 weeks in the dosing schedule, these cytopenias that were probably related to the drug did improve. And it did not correlate with a lack of response for hemoglobin. And so overall, this is a pretty well-tolerated drug. It's dosed at a different frequency than things we've discussed up until now. It's every 4 weeks, a kind of a unique dose of 7.1 milligrams per kilogram, and it is an IV, so not an injection like some of the other things we've spoken about. And it requires some pre-medication as well, but I've not known patients to have any reactions in my personal practice. Dose reductions are there if you have someone who ends up with the other cytopenias. So we'll move to a question speaking specifically about the telomerase inhibitor imetelstat in lower risk disease for anemia. So now that we've talked about it a little bit, now that it's coming along available, at least in the United States, where would you consider using it for the management of lower risk MDS and anemia? Still less clear, maybe ESA refractory, perhaps ESA ineligible, those who did not respond to luspatercept, or those ESA refractory and ineligible patients and people who did not respond to luspatercept. I think these answers will be interesting. Great, thanks for answering. So I'm glad not that many people are unsure. And ESA refractory or ineligible disease may be something to consider, but you are correct that most people are not jumping straight to imetelstat given we've had such good data with luspatercept. Given the timing of these trials, we do not have a lot of data in the present time for those patients who had had luspatercept and then ended up on the eMERGE trial. And so I completely understand how everybody got to the majority response there of the last one. I think we're still going to learn, and the NCCN guidelines really tried to take into consideration how we were going to sequence these, but you'll see more clinical evidence coming about these as we have more real-world experience. If you could advance the slides, please. Thank you. So we've talked a lot about lower risk disease, predominantly those with anemia, and now we really need to move into the higher risk disease space because this is also an area of great need for our patients. So now we'll talk about Christine. She presented with higher risk MDS in the setting of a hemoglobin of 9, also thrombocytopenia, but in this case she had increased blasts, so that space-occupying lesion of the bone marrow, and unfortunately 3 cytogenetic abnormalities, and also had an IDH1 mutation. As with most people, transplant isn't what would jump to mind given her 12% blast. Perhaps she's a little bit older, has medical comorbidities, and she was started on a standard of care for many years of azacitidine. But unfortunately, after she had a few cycles of therapy, she had not yet responded. So we need to decide clinically what we should do for her. And I think it is a good question what the utility of the IPSS-M is in the high-risk setting. Even though that publication's been out since May of 2022, I think people are still learning how to use it. Where I honestly find it most useful is actually in the peri-transplant setting for those who are going to proceed to that potential path to cure. And we're learning about what it means for azacitidine responsiveness, decitabine responsiveness, and how we think about it. But next-generation sequencing is an extremely useful tool for capturing mutations. These are still mostly targeted panels. I'm certainly aware of those who argue for whole exome as its cost decreases, but I think you'll see these targeted myeloid panels used most frequently going forward. But we have this data for her. I will be honest, it might be less likely out in the world to have 3 cytogenetic abnormalities and an IDH1 mutation, but that's why we look. We know it might be rare, but that might open up different therapeutic opportunities for an individual patient. And so what should we do? Now she already hasn't responded to what we currently consider the standard of care, or should we have considered first-line IDH1 inhibition instead of HMA therapy? And I think probably depending on the provider she saw, that might have been discussed even in the beginning, especially given the lack of donor for transplant. And I say that as a card-carrying transplant physician. Most people do not think that an IDH inhibitor would be sufficiently cytoreductive prior to a reduced intensity preparative regimen. And so it's really something to think about how we sequence these in terms of high-risk disease. We're very much about the path to tumor reduction, but also what the destination is for the patient. Currently, the NCCN recommends for high-risk disease still this split of eligibility for transplant. We're trying quite hard, actually, to get away from that for a number of reasons. Many more people are eligible for transplant in the current era, and that's due to haploidentical donors, greater numbers in the unrelated donor registry, and the fact that even older, perhaps less fit individuals are able to tolerate, even into their late 70s, reduced intensity preparative regimen. But as we stand right now in guidelines, there is this bifurcation for transplant or not. And then in a patient like this, azacitidine could be considered, single agent ivosidenib, given that mutated IDH1, followed by transplant. The same is true for decitabine. Most people use those somewhat interchangeably, though there may be a case where we discuss it differently later on. We're still just trying to reduce the tumor burden. Oral decitabine is viable, as is high-intensity chemotherapy. We didn't give Christine's age, but usually we reserve induction chemotherapy for those who are a bit younger. So always something to think about. But what is just nice is that ivosidenib, and Guillermo alluded to it, it was so gratifying to see this really pursued for a rare subset of MDS patients because the response rates are very meaningful. CR, you can see there almost 40%. That's really just as good as HMAs in some series, and overall response rates even higher. And what is nice about this is it's an oral option. If someone's going to respond, it's usually quite quick, somewhere between 4 and 6 weeks. Certainly there are a few side effects that we watch for, like differentiation syndrome, but it can be very meaningful, and the survival is favorable. So always look for the mutation, and then use the agents we have if we can. That differentiation syndrome is something I counsel patients about and I monitor, but in the MDS setting, when dosed at the standard 500 a day, it's really quite manageable and not as significant as has historically been seen in AML. So really something to think about. I think at this point I'll turn it back to you to talk about a different molecular subset of these patients.
Thank you, Amy. So now we are gonna be dealing with like a major problem that Dr. DeZern and I probably deal in around 30 to 40% of our patients, and is that of the P53 mutated patient. Now in practice, probably this is around 10% of the patients, I'm not sure anymore, but in referral cancer centers like Johns Hopkins, as patients with therapy-related disease, complex karyotype have this particular mutation, and as you will see, this is a problem maybe with some potential help coming. Anyway, so now Christine comes with MDS, again is tired, you do CBC, hemoglobin is 9, now this patient is thrombocytopenic, you do your bone marrow test, now this patient has 10% blast, remember normal is less than 5, you do your chromosome analysis, and instead of being XX, she has 3 abnormalities, so we call this a complex karyotype, you run your NGS test, and unfortunately, you come with the fact that this patient has a P53 mutation. At this point, you are not ready for transplantation, or maybe this individual doesn't yet have a donor, although this sometimes actually changes. So now the discussion is, what do you do with this patient? Is the hypomethylating agent-based therapy such as azacitidine, decitabine, oral decitabine, cedazuridine, the standard of care versus, let's say, induction chemotherapy like AML type of approach? Would you consider a clinical trial, and would you consider a clinical trial actually with a BCL2 inhibitor such as venetoclax? And then what if this patient actually for some reason overexpress this retinoic acid receptor pathway? Will that be something that maybe will make you think different? So we're going to be hopefully discussing this next. And then the key question is, what are the implications of this diagnosis? This is actually today devastating diagnosis. The survival of these patients is around 11 months, something like this, and it's kind of like this number. Very few studies, if any, actually have been able to push it actually beyond this figure. They may or may not respond to therapy, so for a while you think you're doing okay. Sometimes we can't even take these patients to transplantation and we think we're doing great. Probably 90 days post-transplant, this patient will be coming back with disease. So very complicated decision. You know, what is the choice of therapy? Do you take this patient to transplant? At what time do you take the patient to transplant? Should you do some therapy post-transplantation? Occasionally, all this works out and we can extend the survival beyond those 11 months that I just mentioned. So very complicated condition. So this is actually kind of the natural history of the survival of these patients. This is this validated analysis, but there are actually multiple series that show this. So if you're not very familiar with this, what you're gonna hear is whether you have the mutation or not, and then you're gonna hear this concept of monoallelic versus biallelic mutation. This is actually quite important. So how do we define that? There are different ways. I'm gonna use it like the one I memorized that is quite easy. So a biallelic is someone that has more than one mutation, so that's straightforward. Someone that has a variant allelic fraction of around 50%, or someone that has one mutation plus deletion of chromosome 17, because that chromosome basically contains the p53 gene, so if you're deleted, you don't have it. So that's kind of a way to really think about this. This BIF threshold may or may not be universally accepted, etc. But you will see that patients with biallelic disease, actually, they really have a very poor prognosis. So you're going to hear about no mutation, monoallelic versus a biallelic mutation. And right now, the only therapies that are associated with some type of response are the hypomethylating agents. They are actually kind of agnostic to the mutation in terms of response, but they don't really prolong the survival of these patients very significantly. Occasionally, you can do that. You may remember there were like 10 days decitabine, things like that. This was actually never really proven in further studies. There's some data that maybe oral decitabine cedazuridine may have some activity or beyond what you see with IV decitabine, but this is the best thing you can do. And most likely, most of us will not give chemotherapy, meaning induction chemotherapy, to this type of patients because you basically give the patient all the toxicity and very little of the benefit. So this is basically a very difficult situation that is actually most of my practice. As you know, venetoclax, this BCL2 inhibitor, is kind of the standard of care in acute myelogenous leukemia. It is not actually approved for high-risk MDS, but the United States and in Europe, we very commonly use this kind of combination. And we know that this doublet, this is how we refer to these combinations, are quite active in terms of responses. We're all waiting for this Verona trial, so read at some point next year. There's a number of studies that have already tested this combination with azacitidine and venetoclax in MDS. We see a nice rate of response, can be actually as high as over 80%. And actually, in the p53 mutated group of patients, we don't see that the response is actually lower in general, but they don't really last, actually. So you have a response that lasts for a very short period of time, and there is no data to indicate, actually, that the BCL2 inhibitor prolongs the survival compared to monotherapy with a hypomethylating agent in the p53 mutated patient. So sometimes we use this doublet if we're going to take the patient to transplant. Maybe that accelerates the time to do so. But if the patient is older and is not a transplant candidate, probably in p53 mutated patient, actually, you will not like to use this combination because it's a little bit more cytotoxic than the single agent. Again, this is something that as leukemia doctors, we do this all the time. Maybe in community it's a little bit more complex, but you will see some cytopenia. So we actually, in my center, admit these patients to the hospital for at least a couple of weeks during the first cycle. They receive antimicrobial prophylaxis, and overall the mortality rate right now in our hands is very low. But if you don't do these things, you may actually run in a little bit of a trouble. And then the other issue that you can maybe think from this slide is the dose of this venetoclax. So there are different ways to do this. In MDS, we don't give the 28 days that you're supposed to do in AML, so we start maybe at 14 days. But the reality is that we decrease the dose of the venetoclax very quickly through subsequent cycles. And the other issue is, in our opinion, you need to give antifungal prophylaxis with an azole, and you need to learn actually how to dose adjust the venetoclax based on the azole that you give. And if you were at the meeting yesterday, you heard the debate of 28 days in AML versus the 7+7. So we don't even know how many days of this to give in AML. So imagine in myelodysplastic syndrome. So maybe you start 14 and then you bring down the dose quickly. I mentioned this already twice. We are really I am kind of anxious about this because I want to retire with a positive study in high-risk disease. And you think he looks kind of young. But if the study fails, the reality is that we will have to come with a phase 1 combination, a phase 2 combination, a phase 3 combination. So we've been doing this for 20 years. I don't know if I have 20 years of academic life. Amy has that, but I don't know. So the bottom line is we better have the study positive, or we come with some magic drug that basically deletes this disease very quickly. So this is going to be a very important study one way or another, and so we should hear from this Verona trial in high-risk MDS very quickly. We at MD Anderson had been kind of lucky or blessed by the fact that we had access to this oral data. To say this is actually an interesting journey, because at the beginning we were thinking about this drug, it's kind of like a me too of the IV decitabine, just a simple way of giving an oral compound. Our patients many times, if we are successful, can be receiving these hypomethylating agents outside the P53 for many months. Actually have someone that is now 13, 14 years on azacitidine, so injection few days every month, this gets long, I would think. So an oral approach, something that we always wanted to have. But there's something else. This is actually decitabine with an inhibitor of cytidine deaminase known as cedazuridine. So this drug actually, we don't have proof of what I'm telling you, appears to be a little bit more potent than IV decitabine, maybe the subcutaneous azacitidine. No proof of what I just said. That's actually our impression. But when we developed it and got it approved a couple of years ago, the next step was we need to combine this with venetoclax. And then we came with this kind of idea of, can we develop what we call total oral therapies for our patients? And I'm very proud of this work, actually, because this is now translating from MDS to actually acute myelogenous leukemia in the older. So we're developing, or we have developed doublets and triplets with this backbone of oral decitabine, cedazuridine, venetoclax plus IDH inhibitor, FLT inhibitor, menin inhibitors. Maybe you heard this SAFE trial. So this work that Amy and I did together with this oral decitabine, now these combinations, and now moving into really potent combinations. Now this, from the MD Anderson, this needs to be proven in other studies, gives you an overall response rate actually of 95% in all comers with high-risk myelodysplastic syndrome, taking 5 pills in 5 consecutive days, and then the venetoclax on the first cycle for 14 days. And it's not much more toxic than the azacitidine venetoclax. I think this will be really, if proven to be this safe and active, really important. So that's something to keep in mind. May not be like a magic new thing that we're doing, but a really effective oral way to treat our patients. And then finally, actually, this discovery, and as I mentioned earlier, Dr. DeZern is actually leading the studies, that is this very interesting concept. And this is actually something that they are leading here, but we're starting to learn in other leukemias, right? So we're starting to hear about, from the Kiwi trial, a FLT3 signature. Now, this kind of little drugs targeting menin, the MLL, 1% of leukemias, but now they target this Hox pathway. That's actually quite significant. So Amy has been leading studies looking at a subset of patients with MDS and AML, because this is not just unique to MDS, that have overexpression of this pathway, that is the retinoic acid receptor pathway. And if you remember, type of leukemia called APL that we treat actually today without chemotherapy, with a retinoic acid plus arsenic trioxide. So this is really interesting concept, that is to use this kind of differentiation therapy targeting a subset of patients that are actually, I believe around 40% of them, if I'm correct, that actually express this pathway. So they may not be mutated per se for some of these entities, but they actually express this pathway. So this is a really important concept. And here, using a backbone of azacitidine, they are combining it with a very potent ATRA-like compound known as a tamiboriten. So this is actually really interesting, and hopefully it will be positive in terms of the final results, and it will give us actually a way to treat this disease using actually totally different criteria based on this gene expression pattern. So very, very exciting. So with that, we're gonna start closing this symposium. I'm actually extremely grateful that you're staying so late listening to us, so this actually means a lot to us. I think if you're gonna take something home, number one, molecular profiling is fundamental in this disease. I see my friends from Guatemala, from Argentina in the back. I know you have some gaps there. This is really fundamental. I mean, we need to really make this happen. And you just heard that actually maybe in the future we're going to be treating not just mutations, but RNA-seq signatures. Very, very important. I think all of a sudden we saw a lot of progress in low-risk MDS. And this is kind of a joke for us in this field, because for 20 years, well, 15 maybe, we worked together. The goal was like high-risk disease, high-risk disease, high-risk disease. And then all of a sudden we are developing all these drugs in in low-risk disease. Actually, to the point, that it's difficult to think about if a company comes now with a new drug for low-risk MDS, how do you develop such a drug? Because we have very good first-line therapy with luspatercept. Now we have a second line with imetelstat that is actually so very powerful. So this is actually quite interesting and is really good for our patients. This molecular annotation of these patients will tell you that some of these people may have IDH1 mutation, maybe IDH2, this is not approved. Some of them actually may have a FLT3 mutation. So there's some potentials for targeting, but the fact that we have an approval with monotherapy, with an oral inhibitor of IDH1, for that particular group of patients actually is quite significant because, as you saw, this is actually like night and day, treating with monotherapy with a very effective compound. So I wish actually this was 20% of our patients or more. It would be really fantastic. And again, people are already thinking about combinations. What do we do in first line? Can we do better than commands? Can we do better than 70%? And with the high risk, we're waiting. Hopefully next year, I'm pretty sure there will be a lot of symposiums if that study is positive, so there will be a lot of celebration. Actually, I think people will be very happy because this community, our patients actually really need that study to be positive. So let's pray that that happens. And then we didn't have time to discuss a lot of what's happening in transplant, but we're seeing a lot of transplant progress. We're transplanting older individuals. We're transplanting actually more than ever. And if we put this together with this kind of oral therapies, I think actually that we will have made some contributions to the care of our patients with myelodysplastic syndromes. And with that, I think we're almost at the end. So yeah, there's some questions. No, please go ahead. Well done. And I guess we're going to go through this. So reflect on your evening's presentation. What did you learn today in both low-risk and high-risk disease? IPSSM risk calculator is a convenient, useful online prognostic tool. I think I conveyed that to you. It's free. You just need to go to Google and type IPSSM. Commands continues to support first-line use of luspatercept. That was very clear from the data. We heard from Dr. DeZern imetelstat as a new option for second-line patients with anemia and low-risk disease. And then again, this use of patients with IDH inhibitors, in particular ivosidenib, for IDH1 mutated patients, where you can use this drug as a bridge to transplant or not. This is actually highly effective targeted approach for our patients. So if we can vote on this, thank you. And I think there are some good questions, and actually we're open to questions from here, right? So let's vote, and I don't know if there are more slides, I don't remember. Okay, perfect. So, yep. So I think people got it. And we have questions there, but we're also open on the floor. So why don't we start with some of the questions there?
Sure. So I think this is a very clinically applicable one. In lower risk SF3B1 negative disease, what would you choose, luspatercept or imetelstat? Is there any role for telomere length testing prior to making that choice?
Go ahead.
No, I think it's a thoughtful choice. And even though imetelstat is in fact a telomerase inhibitor, it's not so clear that knowing by flow cytometry FISH the length of the telomeres in the granulocytes and the lymphocytes would allow that to be a biomarker for therapeutic choice. I think we'll continue to use anemia and red cell transfusion burden as in this study. For me, I would choose imetelstat first, I misspoke. I would choose luspatercept first, not imetelstat, in the SF3B negative patient there, and save imetelstat for second line. Is that what you do?
Yes, and is the label. I think that will be the kind of approach that you will do following NCCN guidelines right now.
Another very fair question: is there a role of transplant in lower risk MDS? Do you ever send low risk patients to transplant?
Okay, so I don't know who wrote this question, but I didn't plant it. I think this is the next frontier. The answer is no. By and large, you will not be transplanting patients with low-risk disease. For sure, you will not be transplanting an SF3B1 K700T mutated patient. But I believe we can cure low-risk disease with transplant. So you're thinking, what is he saying? Okay. I think we need to start thinking about who are these patients that we call low-risk disease that we actually can cure upfront with transplant. It's all about risk-benefit. We're transplanting better, safer, older individuals. So I'm going to give you a couple of examples. Patients in second, third line therapy, we used to call this low-risk hypomethylating agent failure. survival around 14 months. We don't know what the natural history of imetelstat or luspatercept failure is, but that could be consideration. But actually, what I think the question is this phenomenon of what we call upstaging using the IPSSM. So let me explain what this means. When you do the IPSSM on Google, or whatever you use, it gives you actually both the IPSSR and the IPSSM. And for most of your patients, you're going to see that the survival is worse for the same patient when you calculate IPSSM than IPSSR. That's because the burden of the mutations, so the number of mutations, is a negative factor. So you have this phenomenon of patients with lower risk disease by IPSSR that may have intermediate high-risk disease actually by IPSSM. Some of these patients could have 4, 5, 6, 7 mutations. So one question that I have is, are these patients candidates for transplantation? I am not suggesting you do so. I think we need to understand actually if transplant helps these kind of patients with high molecular burden, but this will be a group of patients with low blast, maybe not very bad chromosomes, that have an anticipated, predicted poor prognosis based on their molecular characteristics that could potentially benefit from transplant. So yeah, you will not be probably transplanting many of the patients we discussed today, but I think right now we're saying the guidelines actually say you don't transplant these people. That may not be correct. And then you need to follow these patients, and they may still be low-risk disease. That may be actually the sweet spot to go and cure these patients with transplantation. But I think it's something that you individualize. Very good question, actually.
It is, and it should not be viewed as an absolute no ever. Transplant is always a gray area, so I also think very similarly. What is your treatment of choice when multiple high-risk features are present? TP53, high blast count, and complex cytogenetics. These are patients where the conventional teaching, to contrast to the last question, is they need to get to transplant one way or another, which I don't disagree with, but you really do have to factor in what intervention you think can decrease all these bad things that we just listed. I will be honest, I am more of an oral decitabine for this type of patient, and that's for several reasons. I'm often candid with them that I probably can't cure them. And so even if we are going to try for the potential path to cure of transplant, I want to make sure that they have as much quality of life as possible even before we get there. And so I think it can be a very individualized path, and then certainly a clinical trial if we have something that they would be eligible for.
No, I totally agree with you. This is actually becoming a major challenge. If we were talking together 2 years ago, we will say, oh, we have the anti-CD47, maybe the TIM3, maybe the APR compound, but all those trials actually, they are kind of negative. Maybe because we were targeting this P53 group of patients. Actually, today I'm not aware that we really have a lot of good trials for these patients. So age will be important in an older patient, not transplant candidate, etc., not a clinical trial. I totally agree with your suggestion. And if you're lucky that you have an access to some type of trial, then you should consider it. But this is really difficult today, actually.
Here's another good one. We've focused a lot on anemia, but other cytopenias are important too, right? And so does luspatercept or imetelstat have any positive effects on platelets or other cell lines?
Okay, so what I'm going to say, you have to understand it because I don't want that you go out of here thinking luspatercept is great for platelets. But when we designed the studies with luspatercept, the idea was that it was going to only help with the anemia. Then very interestingly, on the Medalist trial, we saw bilineal and trilineage responses. This was actually published in Blood a couple of years later. So occasionally, in patients with anemia treated with luspatercept, you see an improvement in platelet count, you see an improvement in the white count, sometimes the 3 lineages. We don't know how to predict this. We don't know what are the bases for this phenomenon, but this happens. Indeed, actually, there's a study with luspatercept looking at these patients with significant cytopenias. So you will not give this drug to treat thrombocytopenia. The way you're going to take my information is that in a patient with anemia, you probably are not going to get the platelets worse or the white count worse. So it's safe. Now, with imetelstat, that's a little bit different, because if you saw from the presentation the data that Dr. DeZern was showing us, this drug is associated with significant thrombocytopenia and significant neutropenia during the first few cycles of therapy. So indeed, actually, most likely you will be cautious using this compound in patients with severe thrombocytopenia and neutropenia. So we need to learn more about this phenomenon, but this is, in a way, something that will differentiate luspatercept from imetelstat, and it's likely why today, actually going back to that question, luspatercept will remain for now a first-line drug, and then you will use luspatercept as a second-line drug, because probably you would not like to use a drug that induces thrombocytopenia and neutropenia up front. You will maybe sequence that a little bit. But we need to really understand that. The severity, the complications of those cytopenias with imetelstat, they are not really severe, but they happen, and it's something that will worry any clinician that uses this compound. So this is something that may differentiate one compound versus the other.
And I think I'll just put a plug in. We're not stopping all investigations in low-risk disease. We certainly know that we're going to need more drugs as these patients live longer. And elritercept is a new drug that'll be coming into a phase 3 in 2025 that has a distinct but somewhat analogous mechanism of action to luspatercept, but it has a real effect on the platelets, and that is known. And so these patients that are not anemia predominant may have other therapeutic options in the...
That said, I would like to see someone in a drug company developing drugs for platelets, right?
Totally.
So we need actually drugs that help us with thrombocytopenia. That would be nice. That seems that we have conquered anemia, right? So.
We'll just take one more. I think we've answered most of the details of the rest. Are we making strides in delaying progression to leukemia? Because neither one of us has said that.
Okay, so this is a good question, but I'm going to take 2 seconds. I had a very famous professor in Philadelphia. He discovered, isolated the erythropoietin protein, not the gene. And in those days, these individuals didn't care about patents or being rich or getting biotechs and these kind of things. His name was Dr. Eslev. He died around 20 years ago. But he still was my teacher. And I never thought I was going to be an MDS doctor. But he told me, look, I don't know why you care about this disease. In those days, I don't think they knew pre-leukemia. So this disease, don't worry about it. They transform, they die. Okay, fine. Irony of life is like 10 years later, I became chief of section of MDS at MD Anderson. So the first question I asked was, what do they die from? And actually, patients with low-risk MDS die from complications intrinsic to the disease. They die from infections. They may die from the comorbidities. I mean, around 50% of them transform. Indeed, this was replicated not too long ago. So is transformation important? Absolutely. But in low-risk disease, it may not be our main goal. But my hypothesis is, and we'll see if I'm right, that with the long term of the luspatercept, with the long term of the imetelstat, eventually we will see changes in the natural history of the disease. We saw that actually with the JAK2 inhibitors, right? Drugs that decrease the spleen, okay, you feel better, but now with longer follow-up, these people are living longer. So I think we will see improvements in the natural history of these patients. So there will be less transformation, but that's a hypothesis, and we need to really see. I think if you are able to restore erythropoiesis and these patients become transfusion dependent, the natural history needs to change. But we need to see that, right, Amy?
Well, and I think the other thing to emphasize in what you said is the goals for any patient, for drug development, for being at the bedside, are quality and quantity of life. So I actually personally counsel my patients to focus on the whole paradigm, and let's not worry concretely about 21% blasts. We just need to keep pushing and pushing that metric. Exactly. And so that should be how we develop our drugs and how we sequence the agents we have.
Thank you.
Okay.
Thank you very much. And it's always an honor to talk to you. Thank you.